This program is brought to you by Emory University.
Good morning, everybody. Happy Friday. Welcome to Friday Morning Fellows Conference. Our speaker this morning, as you can see, is Dr. Graham Husband. Graham is a first-year fellow in the clinical track, did his medical school at University of Mississippi and then residency at UAB, and he's going to talk to us about use of cardiac MR and pericardial disease. Take it away, Graham.
All right, thanks, Dr. Williams. Really excited to be here. Thank you guys for coming into the opening speaker of ACC 2024. So thank you very much. Like I said, my name is Graham Husband, one of the first-year clinical fellows, and today I wanted to present a case on cardiac MR and pericardial disease. That was really prompted by a case that we had on the HERS service back at UH a few months ago. So just kind of diving in, no disclosures to report. Objectives. So I really want to dive in and start looking at the current clinical guidelines and practices on imaging and pericardial disease with a specific focus on imaging. Then jump into identifying the strengths and weaknesses of cardiac MR, particularly as it relates to the diagnosis of pericardial disease. And then finally wrap up with the utility of cardiac MR to augment our management of pericardial disease. So I'll open with that case that I was referencing. A few months ago on the HERS service, we had a 60-year-old male. He came in with 2 to 3 weeks of dyspnea on exertion. He'd had a recent viral URI, had gone to a couple of urgent cares over the past couple weeks, received various courses of antibiotics and steroids. Not totally sure what he got. That's just kind of what he told us. Past medical history for him included HIV with an undetectable viral load. He was very compliant with his ART therapy, as well as hyperlipidemia, for which he was on atorvastatin. Whenever he presented, he wasn't particularly tacky. He was slightly hypertensive, a little bit on the tachypnic side, but was satting okay on room air. His initial exam was notable for some lower extremity edema. He had some jugular venous distension, bibasilar crackles. Labs were notable. His troponins were normal. He had an elevated proBNP and a normal ESR. While he was in the ER, he ended up getting a CT chest that demonstrated moderate bilateral pleural effusion and then a moderate pericardial effusion. So from here, the kind of the workup took off. He ended up getting an echo, showed some septal bounce, possible ventricular interdependence, redemonstrated that pericardial effusion, and then also notably showed some diastolic flow reversal in the hepatic vein. So this really kind of led down the pathway of something really going on in the pericardial space that's causing all of this. He ultimately ended up getting a thoracentesis, cardiology, and infectious disease ended up getting involved. But all of this led down the pathway of him getting an invasive assessment. So he did end up getting a right heart cath with pericardiocentesis, as well as a left heart cath, which showed angiographically normal coronaries. But you can see over here on the left, pre-pericardiocentesis, all of these filling pressures are rather elevated and they're equilibrated throughout the 4 chambers. The RV also demonstrated the classic square root sign. He ended up getting a pericardiocentesis, and the right heart cath was reperformed. About 200 cc's were pulled off. There really wasn't any appreciable change in any of our hemodynamics here. We did see some improvement in our pericardial pressure. So at this point, the patient, this was his initial presentation. He was at Emory Decatur. He ultimately got discharged with some PO Lasix, and outpatient cardiac MRI was ordered. All seemed well, but then he came in, got his cardiac MR at EUH, and during this presentation, he was noted to be grossly volume up. He was dyspneic and actually had a tough time laying flat for the exam, and that prompted direct admission to the HERS service. So MRI findings, I want to show the images a little bit later here, but just kind of talk about what was seen here. There were findings of septal inversion, a thickened pericardium measuring 4.7 millimeters, that redemonstration of the circumferential effusion smaller than compared to what was seen on the CT, and then no delayed gadolinium enhancement. And so whenever I got called for this admission, the first question I really had was, why did we get this cardiac MRI? Taking a look at all the imaging and all the other data that we had up to this point, we had a pretty good diagnosis of constrictive pericarditis. We had pretty solid echo findings. We had invasive hemodynamic assessment. All things considered, we had a pretty slam dunk diagnosis. And so the question came to my mind is what did this cardiac MR add to the management of our patient? And so that's what really led to giving this talk and kind of some of the looking into the background of how we can use cardiac MR to augment the management of our patients with pericardial disease. So like I mentioned, I want to go over some of the guidelines. As you can imagine, there aren't a ton of randomized control trials for pericardial disease. There's no real American guidelines on diagnosis and management. Certainly there are position papers out there outlining recommendations for clinical practice, but really the only guidelines we have available are from ESC in 2015. So these are all the ESC guidelines. I don't plan on going into this in any detail here, but in the upper left, you can see they're talking about myocarditis and pericarditis. In the upper right, looking at some constriction. And then these bottom two down here are looking at patients with pericardial effusion and again with constrictive pericarditis. And I just highlighted all the mentions of cardiac MR. Whenever you sit there and you look at these guidelines a little bit more closely, it wasn't abundantly clear to me what exactly the cardiac MRI was adding in our management and diagnosis. Certainly, it can identify things like myocarditis. We can certainly see things like hemodynamics, but a lot of that stuff in many of our patients we already have. So we really, wanted to figure out why we would get a cardiac MR and what it's really adding, particularly before we order a study that's not as commonly obtained. So imaging of normal pericardium, just as a quick description, I'll show an image here in a second, typically appears smooth, thin, low intensity structure surrounded by hyperintense mediastinal and epicardial fat. It tends to appear thicker on CMR relative to echo or CT due to artifactual effects when sequencing with MR. Generally, it's normally described to be less than 3 centimeters, and that's considered to be normal. So here's just a quick image showing cardiac MR of normal pericardium. Here, these are just a couple different sequences without jumping too much into what's going on. But I just wanted to kind of show, and I have some arrows that have been added here, kind of demonstrating some of the normal cardiac MR findings. So this red arrow here on the far left is demonstrating that small, thin, linear structure, hypointense. And then we can see a little bit of fluid in there, that yellow arrow that's pointing to some pericardial fluid. We can kind of see this throughout all of the images and the different sequences we have here. You notice, and this is kind of important whenever we go to some of the later slides looking at more diseased pericardium, the pericardium here is not the most noticeable structure on our MR. Certainly there are other structures that are far more prominent. And I think that'll whenever diseased pericardium comes forward later, we're going to see that more prominently. So here, not to dive too deeply into the different sequences of what's going on with cardiac MR, but I wanted to spend some time here just looking at the toolbox that we have available to us. There are a lot of different sequences we can use with cardiac MR to try and figure out what exactly is going on with the pericardium. And this is a really helpful graphic that I found that I think can give us a lot of information and educate us on what we can look for whenever we have diseased pericardium. This first, a couple of the things we have here is we have the cine images. These are particularly valuable as it relates to identifying physiology, and we're going to see some more of those later. The T1 and the T2 images are really important because the T1 images measure how quickly the heart returns to its normal state after being excited, while the T2 mapping determines how quickly that energy that the MRI imparts upon the tissue, how quickly that returns back to normal. T1 generally is more of a marker of fibrosis, while T2 is more of a marker of edema. The T2 stir images, that's STIRT, standing for short taw Inversion recovery highlights areas of abnormal fluid accumulation. And then things like late gadolinium enhancement, that's the contrast agent that we use, tends to highlight scar tissue or damage to the heart muscle. So, as I mentioned earlier, pericardial effusions, obviously have hemodynamic consequences, and cardiac MR can readily identify tamponade. There's plenty of data out there to demonstrate that. We can see things like diastolic compression of the RV free wall, early systolic collapse of the right atrium. We can see the septal flattening during inspiration. It can confirm poor cardiac output via calculation of the forward flow and cardiac index, but obviously cardiac MR isn't going to be something that we're frequently using in our patients with tamponade. And in that sense, whenever we have large pericardial fluid collections, this isn't going to be our most used study, even though it can provide that information to tell us if a patient is in tamponade. I think one of the things that I didn't necessarily realize whenever I was looking into this topic was how we can use cardiac MR to actually characterize pericardial effusions themselves. And whenever I say that, I'm talking about what is actually in the contents of the pericardium in that pericardial space. There was a study that I was looking at that really took a look at, how can we use cardiac MR to determine if we have transidative versus exudative effusions. And so transidative effusions tend to be hyperintense on both T1 and T2 weighted images. Exudative effusions tend to be hypointense on T1 while they're hyperintense on T2 weighted images. And then hemopericardium, just since that can be a concern clinically, it's a little bit more challenging to image just since the dynamic protein and water content changes based on the chronicity of the effusion. I just wanted to highlight an example here. I'm going to review that study that I was referencing a little bit more in the next slide. But this is this is the example of what we can see with transidative effusions versus exudative effusions. So in the study, they just had some phantom samples here. This is just some albumin. You can see an increase in concentrations in the T1 weighted sequence. We can see particularly over here on the left with the decreased concentration of the albumin, much more intense than what we see with our more quote unquote exudative effusion with higher albumin concentration. So the study that I was referencing, published in the European Heart Journal back in August of 2022, they actually took 86 patients with unknown etiology of their pericardial effusions, and then they mapped their native T1 values of the relative effusions and correlated that with protein concentrations within the effusions. So down here in the bottom right, I have some of these graphs taking a look at the correlation between both pleural and pericardial fluid and how that related to the T1 times. We can see here the correlation is a lot stronger in the pleural space, being significant for both the just pleural fluid protein and also the pleural fluid to plasma protein ratio. But the pericardial fluid also had a correlation here, particularly as it related to pericardial protein to plasma protein ratio that was statistically significant. The authors ended up using a cutoff value, T1 value of 3,150 milliseconds to differentiate transidates from exudates. And whenever the samples from these 86 patients, whenever they were ultimately sampled, showed a sensitivity and specificity of 95 and 81% respectively. And so up here in the top right are some of their T1 images. We can see up here in the top, they've sampled both the pericardial fluid and the pleural fluid. And you can see how hyperintense both of these fluids are. And this was taken from a patient that ended up having a transidative effusion. So this is kind of what we're seeing whenever we're trying to characterize effusions that are of unknown etiology. So jumping on to pericarditis, one of the things I wanted to highlight before jumping into cardiac MR is our typical diagnostic criteria. We've got chest pain, friction rub, EKG changes, and new and worsening effusion. In all of this pericarditis, there's only one element that relies on imaging, and that's obviously the effusion. And in many of our patients, whenever we get echoes on them, only 60 to 84% of them are going to have an effusion. And that leaves a very large number out that imaging as a whole is not going to be a valuable diagnostic criteria. And so in this way, it was made me wonder, is there other things that we can use beyond just echo findings of an effusion that could potentially suggest pericarditis? So whenever we look at cardiac MR's role in pericarditis, pericardial thickness is a huge, huge important factor in diagnosing pericarditis. That inflammation that we see with the pericardial thickness and that fibrosis and edema can be seen whenever the pericardial thickness is greater than 3 millimeters. Like I said, it appears hypointense on the T1 weighted images. Another thing that we can use as it relates to the diagnosis of pericarditis is delayed gadolinium enhancement. And that's a really huge tip-off to acute pericarditis, with the reported sensitivity for the pericardial inflammation being reported somewhere between 94 to 100%. So this can be a really valuable tool. The thickness can help us diagnose pericarditis itself, while the delayed gadolinium enhancement can help us determine the acuity of the pericarditis. So this is another great graphic that I found that I thought was very, very helpful in kind of summarizing some of these findings as it relates to pericarditis. Over here on the right, we can see we have the stir images over here, the T2 stir images, and then the gadolinium enhancement. You can see here as we progress through acute to recurrent to chronic and more burnt out pericarditis in the gadolinium enhancement, you can see how bright everything is. And then as we get more and more burnt out, we can see we lose some of that gadolinium enhancement over time. And then the stir images over here in this left column, you can see how bright the pericardium is appearing. And as we progress further down, we get less and less of that intensity that we see on MRI. Over here on the left, this is taking a look just at acute pericarditis and acute diffusive pericarditis. We can see here how prominent the pericardium is, reminiscing back to those images of normal pericardium. You can tell how much more prominent the pericardium is on these MRI sequences, whereas earlier, it wasn't exactly the most notable structure. Now we can see how prominent that is and how well it shows up in many of our patients. Additionally, one of the values that we have here, I think that's really interesting too, is in post-MI patients that get pericarditis, they come in, they're having recurrent chest pain, and the wonder is always, could they be having an acute event? You can really see and localize the pericarditis to the area post-infarct, and that can be a huge tip-off that this is post-MI pericarditis. And that's one of the values I think that cardiac MR brings to the diagnosis of pericarditis in these patients. Another really important topic to address as it relates to pericarditis is certainly recurrent pericarditis. Most of our patients aren't going to have recurrent episodes, but we're talking about, about a quarter of our patients, 15 to 30%, are going to experience recurrence. And more importantly, those who have their first recurrence, about 50% of these patients are going to have subsequent flares. So there's a lot of morbidity associated with this, associated with recurrence. And we want to be able to readily identify patients that once they have recurrence, we want to be able to readily identify that, treat it appropriately, so that way we can reduce the number of recurrences and any potential complications they can have from recurrence. So this was there was a 2018 study, retrospective study of 200 patients at the Cleveland Clinic. And what they were looking at in this study was use of cardiac MR to help delineate patients that had recurrent pericarditis. So all of these patients had had their first episode, and all had had at least one recurrent episode as well. And what they looked at in just a couple, really what they looked at most closely was use of delayed gadolinium enhancement on cardiac MR to see how that altered their diagnosis. And what they found was that there was an independent association with recurrence whenever delayed gadolinium enhancement was seen on cardiac MR, with an odds ratio of 1.28. So there was some added value in patients where maybe we weren't totally sure if the patient was having an episode of recurrence in helping to diagnose this. The authors of this paper actually added delayed gadolinium enhancement to the traditional diagnostic criteria for recurrent pericarditis. And then we can see the receiver operating curve over here on the right and how this improved the area under the curve for them. At the end of the day, recurrent pericarditis, it's still a pretty challenging diagnosis to make. The sensitivity and specificity was 70 and 76% respectively. So certainly, it's not exactly world breaking, but there is some value in patients where we're not totally sure what's happening. We're not completely sure if the patient is having an episode of recurrence. Maybe it's different from something that they've experienced in the past. So there is some added value that we can get here in having patients who could potentially be having recurrence and getting cardiac MR. The next thing that I want to go over is this was another Cleveland Clinic study that I thought was really valuable because it took a look at guidance of therapy in recurrent pericarditis. So many of our patients with recurrent pericarditis are going to get a lot of steroids, which comes with its own set of complications. And if we can reduce the amount of steroids that they're getting, that's better for the patient. But in addition to that, patients with recurrent pericarditis are at increasing risk for things like constrictive pericarditis and subsequent procedures like pericardiocentesis, windows, pericardiectomy. And so if we can find ways to help reduce those things for the patients, then it could potentially be valuable. So in this retrospective study of 507 patients, also at the Cleveland Clinic, roughly divided in half, about half of them had cardiac MR that was used to guide management, and the other half did not. It was really interesting because it showed that the patients that had cardiac MR associated with guidance of management and recurrent pericarditis, you can see here that they were going to have decreased number of prednisone pulses, which the authors in this case defined prednisone pulses as their marker for an episode of recurrence. The total amount of prednisone that the patients ended up getting was significantly lower. And in addition to that, the complications and need for procedural intervention was lower as well. So there wasn't any significant increase in morbidity associated with using cardiac MR and the associated reduction in steroid dosage. So I think this shows here that in patients that are having significant number of recurrences, cardiac MR can provide some pretty valuable information and guide our therapy to try and reduce exposure to things like steroids and potentially guide us away from needing procedural intervention without any increased risk for morbidity or mortality. This here is an image from that particular study, just taking a look at some of the changes that we see in patients with recurrent pericarditis. Over here in this left column, we see a patient with their baseline image. We see the T2 stir image here. We can see some really thickened pericardium here. Obviously, we have a positive arrow sign that kind of lays that out for us. And then down here in the bottom row, we see that delayed gadolinium enhancement as well. So we can see a patient that's having an active flare of recurrent pericarditis. There's some evidence of inflammation going on based on these images. And then post-treatment, we can see, the pericardium kind of dating back to whenever we were looking at those normal images of pericardium earlier, we can see a much more normal looking pericardium, a much less prominent structure. So it's suggesting that we had successful treatment of the patient's episode of recurrence. So the next thing that I wanted to jump to, pericardial constriction being what prompted this whole talk, I wanted to talk about pericardial constriction and the use of cardiac MR in these patients that have pericardial constriction. So at the end of the day, pericardial constriction is a result of thickening and calcification of the pericardium, and it impedes filling during diastole. And that's what leads to this more or less a type of heart failure syndrome where we see the volume overload, the lower extremity edema, the effusions. In general, talking about thickening, we've kind of gone over that we can see thickening on cardiac MR as it relates to the pericardium. But these calcifications, this is kind of an area where cardiac MR lacks, is that CT is definitely a far better imaging modality for identifying the calcifications. And just laying some of that out here, you can see these images here across the bottom. This is a CT and an MR sequence from the same patient, just at different slices. The top row being the CT sequence, the bottom row being the MR sequence. You can see there in the top row, I think particularly at some of the more cephalic shots of the CT, I think you can really see the calcification kind of laying out in the pericardium, and it progresses as we move further caudal. And then on the bottom row, we can see the cardiac MR. We can see that thickened pericardium as it wraps around the heart, but we don't really get a good idea of calcification. So that's a big area where cardiac MR kind of lacks in terms of helping us diagnose pericardial constriction. Not necessarily that calcification is a diagnostic criteria, but it's certainly a diagnostic clue. So one of the beauties of cardiac MR and pericardial constriction is that it readily identifies the signs of constrictive physiology. We can find abrupt cessation of diastolic filling. We can see the septal bounce. We can see the variation in septal excursion throughout the respiratory cycle, atrial enlargement, and then our non-cardiac findings of things like constrictive pericarditis, including, dilation of caval and hepatic veins, pleural effusion, and ascites. The beauty, I think, of cardiac MR is it's really has excellent diagnostic accuracy in diagnosing patients with pericardial constriction. In one review article that I found, that 3 millimeter cutoff and the relative interventricular septal excursion, because since we can see the physiology on cardiac MR, when combining those two together, when both of those two things were present, cardiac MR had excellent diagnostic accuracy in terms of diagnosing pericardial constriction. So 100% sensitivity and 90% specificity in that review article that I found, which really provides a lot of valuable information for us whenever we have maybe a patient who echo or echo findings might not necessarily be 100% convincing, and we don't want to put the patient through an invasive test. Another thing that I think is really interesting about pericardial constriction and use of CMR is that it actually has some value in predicting reversibility. So there was a small study that I found. It was only 29 patients, so certainly not huge, not groundbreaking, but it was really interesting because they actually were able to predict with a reasonable sensitivity and specificity, 86%, 80% respectively, that an increased pericardial thickness of greater than 3 millimeters alongside the presence of delayed gadolinium enhancement was highly suggestive of reversibility. Additionally, in all of this, it was associated with a reduction in ESR and CRP, which suggests that we're reversing some of that inflammation. And really what I think they're looking at here is a reduction in the inflammation leading to that constriction syndrome. So I want to jump back to our patient. We've talked a little bit about how we can use cardiac MR and various elements of pericardial disease, talked about, hemodynamics. We've talked about characterizing effusions, pericarditis itself. But really, the central question to this talk is how can cardiac MR assist us in managing our patient? And like I said earlier, big question for me was how did this cardiac MR augment our management of this patient, since we more or less had a slam dunk diagnosis of constrictive pericarditis. So I wanted to jump back into our patient. This here is just an axial slice that we have here of our patient. This is just a still image that we have here. Obviously, the things that probably jump off the page most readily is the pleural effusions that we can see, readily identifiable. But also we can see here, particularly over the RV free wall, we can see some thickening here. You can see some of that effusive process going on. And we can see some of that, pericarditis as well. So this here is our 4-chamber cine. I'm just gonna go ahead and let that play. This is an excellent image. I want to thank Mariana, who was able to hook me up with the cine images. This is an excellent cine image, and we can see here you can really see the ventricular interdependence. There's a lot of that septal bounce that I was talking about earlier, highly suggestive of constrictive pericarditis. And I think we really get a good image of this that, sometimes it might be a little bit more elusive to grasp here in echo. Additionally, I think you can see redemonstration of some of the pericardial anatomy. We can see the visceral layer attached to the pericardium, and then we can see some of this effusion up here, and then we can see more of the pericardium, kind of a parietal pericardium wrapping around here. And then this here is our three-chamber cine. I think here we get a good redemonstration of some of that. Obviously, we're still seeing more of those pleural effusions, but you can see some of that septal bounce that's ongoing. And then we can also see more of our pericardium here. You can still see some of that effusive process. We can see a relatively thickened pericardium wrapping all the way around. But that ventricular interdependence is redemonstrated here. And as we established earlier, that's a really important component of diagnosing uh, constrictive pericarditis in our patients on cardiac MR. All right. This is a short axis view. It's moving a little bit fast here, but the beauty of this video here is we have, in addition to the cardiac cycle, we also have respiratory variation. So the other two cine images, those were breath holds. This allows us to see some of the respiratory variation in our patient here and how that impacts some of the hemodynamics. At the end of the day, constricted pericarditis, we have a fixed space as a result of that really thickened pericardium. So there's only so much space for both the RV and the LV to fill in diastole. And as a result of that is whenever they do filling of one chamber is going to result in impaired filling of another. So one chamber can fill, but only at the expense of the other. And that's why we see some of that ventricular septal or ventricular interdependence related to the septum. A lot of that changes too whenever it comes to respiratory variation. Typically, whenever a patient is inspiring, we see decreased intrathoracic pressures. That's conveyed to the pulmonary veins, that's conveyed to the left atrium and the left ventricle, and they have associated drops in their pressures. But in patients with constrictive pericarditis, we see the drop in pressure in the pulmonary vein, but we don't necessarily see that in the left atrium and the left ventricle. And that actually leads to relative elevation in the diastolic pressures of the left ventricle, leading to a decreased pressure gradient from the pulmonary veins to the left ventricle. And we actually get less filling. And I think you can see some of that here, particularly as our patient inspires. The LV isn't filling nearly as much in inspiration as it is during expiration. So here. So jumping back to our patient, we've kind of gone over some of the things as it relates to our patient, particularly, I think I touched on some of the things earlier that our patient, was this a constrictive, we were able to confirm that this was a constrictive process, but it wasn't necessarily, we had the diagnosis, and how are we going to use the information from cardiac MR to help manage our patient, provide him guidance. So whenever he initially got admitted following the cardiac MR, we got a little bit more history. We learned that probably the process that had been suspected to be going on for 2 or 3 weeks during that initial presentation had probably been going on for 2 or 3 months on and off. He'd received many courses of steroids and antibiotics that hadn't been effective. So this wasn't exactly a fresh process. He'd probably been having it going on for at least 2 or 3 months, potentially longer. We discussed with the patient, we knew he had constrictive pericarditis at this point, and we knew that this was going to keep recurring. The PO Lasix, it was only a temporary fix, and while we were able to diurese him with IV diuretics while he was in the hospital and make him feel better, we knew that this was all going to, this is just a vicious cycle that was going to keep recurring. So we initially broached the idea of referring him to CT surgery for pericardiectomy. He was initially very against talking surgical intervention whatsoever. So we continued some IV diuresis while he was in the hospital, and we were actually able to look into the CMR at the time, because at the time I didn't really understand how CMR would help us understand the reversibility of this. But looking at some of the data that I just presented, we were able to see that the odds of his reversibility with this CMR, we were able to get really concrete data for him and show him that, probably wasn't going to have a reversible outcome. So some of our patients with constrictive pericarditis are going to have reversibility. He's probably not one of those patients. And with that information, we were able to get him plugged in with CT surgery. It wasn't necessarily it wasn't necessarily something where he did any procedural intervention right off the bat, but at least we were able to get that ball rolling for him. He ultimately underwent radical pericardiectomy a few weeks later with CT surgery back at the beginning of February. And so that's ultimately how cardiac MR in our patient, it allowed us to augment some of our management of this patient, despite already having a diagnosis of constrictive pericarditis. We got a really good understanding of what his prognosis was going to be, and it allowed us to give him accurate information as to what we thought his clinical course would be, and ultimately get him the care that he needed to prevent him from having recurrences and keep getting admitted for dyspnea and volume overload. So just to wrap up here, this is a really good slide that I found that I think is just a good summary slide here to go over the strengths and weaknesses of various aspects of imaging as it relates to pericardial disease. Over here in the far left column, we can see echo. Here in the middle, we can see CMR, and on the right, we can see CT. And so each of these imaging modalities certainly has their strengths and weaknesses. One of the biggest weaknesses I pointed out with cardiac MR is certainly the calcification. It doesn't identify that readily. And then obviously cardiac MR as compared to other imaging modalities like CT and echo isn't going to be as readily available. It's something that's a little bit more difficult to obtain, more expensive, and those are certainly drawbacks. But cardiac MR has a lot of value in being able to diagnose and identify pericardial disease. But I just wanted to offer this as a wrap up, just as a quick summary of the strengths and weaknesses, as a quick overview of the various imaging modalities we have at our disposal. So if anybody has any questions, I am more than happy to answer any. So my references.
Thanks, Graham. Very good review of can be very complicated topic. I don't have any particular questions. No, I mean, I think it was great. I remembered this gentleman from when I was on in January. He's very symptomatic guy that I remember. Yeah, I remember just as a service being a little frustrated strong, but remember that, yeah, he was very reluctant to undergo surgery despite how symptomatic and sick the guy was. And I'm glad he ultimately decided to undergo the surgery. And I hope he's doing well, because that's obviously not an easy surgery necessarily, can have a sort of prolonged recovery time, even in a relatively young, healthy guy like this guy was. So questions, comments from the audience about this topic?
Graham, Stan Sherman. Just when you referred to poorly reversible or lacked good reversibility, I guess you were saying with medical therapy, and that's why the push was on to go ahead and send him to surgery.
Yeah, that's correct. That's correct. We were sitting there and debating, since he was very hesitant to talk about surgical intervention. And at the time, whenever he presented, we realized that this has been going on a lot longer than we initially suspected. And so at that point, we were thinking, the odds of reversibility were pretty slim, just based on history and how long this had been going on, probably very fibrosed. So we talked with him about options in terms of reversibility for him with medical therapy, anti-inflammatories. And for him, some of his options were also limited. He was a little bit on the thrombocytopenic side. Platelets were ranging anywhere from like 80s to 100s. So options were a little bit limited for him in terms of doing something like NSAIDs. And so we really needed to cement in his mind that medical therapy probably wasn't going to reverse his constriction syndrome, not to mention that, the rate for reversibility of constricted pericarditis is relatively low, bordering, right around a quarter of patients might have some reversibility with medical therapy. So it was really valuable to get this information because it actually allowed us to get him plugged in with CT surgery. And then it ultimately led to him getting the pericardiectomy.
Hey, Graham, this is Ankit Bhargava from Decatur. I actually was the guy who diagnosed this guy back in November, so I remember him very clearly. But yeah, that was the right question. Why do we do the CMR? And it was strictly for that reason, to see, is he someone who stratifies as a candidate for medical therapy or not? What I would say is the other addition to that process is a pericardiectomy is a very morbid procedure. And so if there was any way that we could avoid doing it, that was really the goal. Unfortunately, we don't have CMR here, which is why we had to expedite it as an outpatient and why he ended up getting invasive testing here to confirm the diagnosis. I have kept tabs on him. He did get his pericardiectomy. He's actually still in the 5E ICU right now. And just kind of highlight it, it's not looking great, right? I mean, he's had like tracheostomy, fungemia, so it's ultimately a hard call, but what other choice did he have? There was nothing that we could do otherwise.
Yeah, his post-operative course, unfortunately, I think Dr. Bhargava, he had a complication during the pericardiectomy, and I think that's led to a tough road for him, unfortunately. But like you were saying, you and Dr. Williams were saying, this gentleman, you guys, I think discharged him on like the 23rd, 24th,
Yeah,
late November. And
that's
then,
right.
yeah, right around then, and then he got admitted to the Hearst service right at the beginning of December. So, the expedited cardiac MR, he, even within that short time period, a week or two maybe, and he was already highly symptomatic. He had a couple of admissions between the time he got admitted to Hearst in December to the time he ultimately ended up getting the pericardiectomy. So it was really valuable information, and it was something at the time that, like you were saying, I didn't have a good grasp on it. And cardiac MR wasn't something that I had a lot of knowledge on, and that's what spurred the whole process, especially because it felt like we, like you said, you had a really good diagnosis and it was pretty concrete, but it provided a lot of valuable information. And without it, I don't think we would have been able to convince him to talk with the surgeons.
Yeah, great talk, Graham.
Okay, well, yeah, great talk, great review, and just like another tool in our toolkit of what is often a very difficult and tricky diagnosis. But yeah, I mean, the key again with suspected pericardial constriction is use all the tools that you can on these folks, be it invasive hemodynamics, echo, obviously, MRI, obviously, and even CT to help sort of fully assess, make the diagnosis and sort of fully assess everything else that may be going on. So good review. And like I said, I hope everyone gets to enjoy some of ACC this weekend, and we'll see everybody next week.
The preceding program is copyrighted by Emory University.